Welcome to Vision Expo East from New York City. I'm Dr. Ben Gaddy, and joined with me is Dr. Patricia Fulmer and Dr. Scott Morris. And today we're going to talk about medical optometry and what does it really mean to have a strong medical component to your practice, or maybe even a practice dedicated to medical optometry. What does it look like, and how do you know when you've made it? So how do you know when your practice is truly medical? Scott, let's start off with you. Tell me the obstacles you see, not only in your practice, but in other practices you try and help develop medical. What's the number one obstacle out of the gate?
Well, I think over the last few years, I spent a great deal of time as a private practice consultant, as a corporate consultant, spending time doing the OD boot camps of teaching people how to build the medical model. And I would say the single biggest obstacle that people face is what's in your brain. It's a philosophy issue. People say, I don't see medical, or I don't treat medical. And the answer is you see medical every day, all day. When we think of just ocular surface disease, that makes up at a minimum 20 to 25% of your everyday population that walks in the door has some form of ocular surface disease. So when people say they don't see it, I said, that's your fault because it's there every day. Unless you have a pediatric practice, 25% of your practice should be medical. That's the baseline. So a lot of times it's mental. And then the second people says, I can't treat it because I'm not on an insurance panel, or I'm not on the right insurance panel. And the answer is if somebody came in and they were a -2 myope, like Ben said, and some days I have days I'm like, man, I just wish one of those would walk in, right? But if somebody came in and said I'm a -2 myope, but I don't have managed vision care, would you see the patient? And the answer is everybody goes, well, of course, they're gonna be cash pay. Well, if somebody comes in and they have a problem and you can treat the problem, who cares who's paying for it? Treat the problem, fix the patient. Many people, you have to remember the average deductible in the United States now is around $7,500 per person. So even if they have managed medical care, especially even at this point in the year, I promise you, there's still cash pay. Whether you take their plan or not, there's still cash pay. Our job as providers is to treat the patient in front of us and not let who's paying get in the way of us being a provider.
Yeah,
Tricia, what about you?
I'd completely agree. I think, coming a little bit from the newer graduate realm, being out about 5 years now, the biggest thing I see when I talk to students and upcoming graduates is that they feel like they're not ready. They feel a little timid, a little scared to jump in, but they're completely prepared. They just have a mental block, like Scott said. They don't think they can do it because they haven't been out. Maybe they've been seeing 2 patients in their school's clinic in a day. But when they get out, you've got the knowledge. You have to trust yourself, trust that knowledge, and trust the fact that you're not alone. Even if you go into a private practice right out of the gate, and maybe it's you and one other person, there is an entire network of optometrists out there ready to help you, colleagues and support systems and mentors. So the mental block, I completely agree, is the number one thing to get over. And then beyond that, realizing that medical optometry is just optometry. You're there to take care of the entire eye, not just the refractive part of it. And if you can keep that in mind, you're going to be able to build a medical practice in no time.
I like what you said, Patricia. The students that are coming out today, those of you that graduated recently, you are better trained than all of us combined.
All of us.
Your training and expertise and the level of your didactic and clinical exposure is exceptional. But what you don't have is the patient experience, the experience of managing a lot of patients over and over, repetition. And that's what a residency does, of course, is it helps you apply all of your knowledge to a high volume of patients in a supervised environment, but obviously not everyone's going to do a residency. And so the confidence level seems to be what people are missing. And if you just had a few cases under your belt, gosh, you would just pick up and you would run with it. How do you see that?
Yeah, 1,000%. I did an ocular disease residency, so that gave me that extra little, confidence booster. And I tell any student that doesn't have, their perfect scenario lined up when they happen to start 4th year, they need to consider a residency. I'm a huge proponent for that. I think extra training is nothing, that will hurt you in any way. That extra year is going to give you so much, exposure, which is really what you need. But say you don't do that. That's okay. Go find your practice, start wherever you're starting, whether it be a retail modality or whether it be private practice, whatever you choose. Do that, but then connect yourself within your local community, within your state community, and find those mentors. Find the people that you come up against a case that you can pick up the phone and say, hey, I haven't seen this ever, or maybe I saw it, but it looked a whole lot different last time. What would you do? And that helps build, that confidence level, because the patient doesn't know you've never seen it. Only you do. Do you feel confident, know that you can handle it, and lean on your support system.
People have symptoms, they have clinical signs, you develop a management treatment, and you code correctly. It doesn't really matter who's paying for it. It doesn't matter what the symptoms, the diagnoses are. How we manage every single patient is exactly the same. Just the disease state is different. So that's number one. Number two, I think the biggest challenge that most, and I don't even say it's the students or first people out, anybody who's going into something new, whether it be the medical model, medical style practice, or sports vision practice, or specialty contacts, the biggest challenge is that, as Ben said, is that level of comfort or security. And really the biggest challenge that most people have is they don't know exactly how to say what they see, or how to teach the patient about what's going on with them. Well, the good news is that's just practice. Just like everybody learns how to talk about myopia or hyperopia or stigmatism or presbyopia or progressives, you can learn how to talk about dry eyes or allergies or glaucoma or retinal detachment or vitreal floaters. It just comes down to scripting. And each one of us have this little cool device in our hand, usually called a phone, that has a recorder on it. There's no better way than to record what you say and listen to it and say, how could I say this better? Once you've done something a few times, you get really comfortable talking about it. And there'll always be nuances for this patient and that patient, but the reality is most people's fear is a fear of how they communicate. Well, we can beat that just by practicing a little bit what we say. And it comes down to, I always tell people, write down a little protocol. If somebody walks in with dry eye, spend 10 minutes of your day, and you have 10 minutes, right? Spend 10 minutes of your day saying, if somebody came in with these symptoms, this is my differential diagnosis, and this is how I would explain it. And then practice. And guess what? Later that afternoon, that exact patient will usually walk in the door. Because once you start thinking about what people are going to tell you and what questions you need to ask, usually you start seeing those things. When I have my student doctors come in, they say, I just don't know how to deal with dry eyes. I said, well, let me ask you this. The next patient that comes in the door, I want you to ask them 2 questions. 1, does your vision ever fluctuate? And if they say yes, does it get better when you blink? And the very next patient comes in and goes, he said yes to both of them. I'm like, cool, it's dry eye. He goes, but they didn't say they had dry eye. I said, they never do. So we just got to make sure we ask the right questions and know how to talk about the right things. And that's something that every single person who listens to this, watches this, reads stuff that Ben and I write, we can practice that.
Actually, if they tell you they have dry eyes, you got a real advanced dry eye in your hand.
You got trouble.
Well, so one of the impetus to have these types of discussion really relates to the changing demographics and environment in the United States. And it's changing very quickly. If you haven't noticed, we have the baby boomer population is fully in the baby boomer range now. And we know that the supply of ophthalmologists is decreasing precipitously. And the number of patients that are going to require ocular surgery is increasing with the baby boomer population. So with less ophthalmologists, more patients needing surgery, do you think the ophthalmologists that are there are going to be able to manage chronic disease like glaucoma and dry eye and diabetes on a routine basis? They need to use their clinical, their skills, their physician skills in the operating room. They're going to be very pressed even to handle the population load that they have. We have to take over the management of chronic eye diseases. And so with that, tell me, in your opinion, what are the main chronic eye diseases that are fairly straightforward, that generate revenue in the practice, that lead to patient retention and an increased perception of what you and your practice does in the community? What are those conditions?
I think everyone could probably yell out the biggest one, dry eye. Anybody have dry eye? I guarantee you almost half of the people that walk in your practice probably have those symptoms if you ask them, and the other half, if you really drilled down, probably have 1 or 2. Used to dry eye was something that maybe your 40, 45-year-old women started experiencing as things changed, and your elderly, maybe your cataract post-op patients, that sort of thing. But now, how many of you guys are on your phones most of the day, or your tablets, or your computers, or your digital device of some sort? We are seeing so many more patients come in with that. whether it's a physiological change or the fact that their lifestyle is driving that disease. Either way, they've got the symptoms, they've got the signs, and they need to be treated. I'd say that's the number one easiest place to start. It doesn't require specialized equipment. You don't have to go out and buy an OCT to manage dry eye disease. You can do that in your chair confidently every single day and get your staff involved, get some surveys going. You can do so many things to build that. And if you get, say, a 40-year-old lady that you've got in your chair and you're treating her, she's probably going to bring her husband. She's probably going to bring her kids. She's going to build your practice, based on that one diagnosis and that one treatment.
Well, and I'm going to add a couple points to that. One is I want you to think about what are the most common disease states you see based on ICD-10 descriptions. So in order: myopia, astigmatism, presbyopia, dry eye, allergic eye disease, hyperopia. So you guys got the first four were refractive disease, but they're a disease state. They have symptoms, they have signs, they have management plans, all that kind of stuff. But and I think we always have to be a little careful when we talk about, well, I'm a vision care practice or I'm a medical practice. The answer is you're a practice. You're not a medical doctor, you're not a vision doctor, you're an eye doctor, which means our job is to treat what walks in the door. And as you build the medical services side of your business, it will build, as Patricia said, the vision side of your business. And if you pay attention on your vision side of your business, if you will, it will build the medical side of your business. You just have to ask the right questions. And once you develop a loyal, because you ask the right questions and you treat the right disease, as Patricia said, we always kind of joke is, who's the most important patient? It's three letters. Two of them are the same. M-O-M. Because mom controls where she goes, where her husband goes, where her kids go, where her friends go, where people she doesn't even like go, right? And the reality is if you can make mom happy, you're going to build your business. And a dry eye patient that you fix effectively isn't worth $75 or $100 for a medical reimbursement. It's worth $1,000 a year because they're usually going to bring in one or two other people who may also have other problems that need to be treated. So if we start focusing on the low-hanging fruit, as Patricia said, with dry eyes, which takes no technology whatsoever, right? I'm guessing everybody has a slit lamp. You're good? You have a slit lamp? Everybody? Okay. And lights? Okay. We'll probably have everything we need to actually be able to diagnose many forms of dry eye.
And ears.
And ears. Maybe more importantly than eyes is ears, yeah. Because the reality is, and Ben kind of says, we joke when we go out and teach this stuff, is that, you can make about 80% of diagnosis just by listening and asking the right question, never even pulling up a slit lamp. Yeah. And so, it is very easy. We just have to be willing to step out and go, my job is to take care of the total patient. And if you take care of them, they'll take care of you.
All right, so let's switch. And by the way, I had in my notes to remind all of you that it is your responsibility to manage the patient when they come in the door, no matter what they have. And that doesn't mean, well, I think they might have a retina problem, I'm going to refer it out. They have a corneal ulcer, I'm just going to refer it out. That's easier to do. It takes up too much of my time. How do I fit that patient in? How do I verify their insurance? How do I make the appointment for the patient? Is that going to slow me down? I think it's going to slow me down. And then if I get a case I don't know what to do with, well, then I'm going to refer the patient out, and then I'm just never going to do medical eye care again.
Well, Ben, you can't set me up like that, right? So, and that's a fear thing, right? I haven't done it before. It's an experience issue, as Ben had said earlier. And once you have done one of these, you're like, okay, well, this is what I do. And maybe there's going to be a little nuance that's different. But most problems you have in your practice is because you didn't have a plan. So when you're sitting around and one of your patients cancels, you're like, well, what's what I can do for the next 20 minutes, right? Instead of jumping on Facebook or jumping on whatever, maybe instead say, if somebody called in and I need to refer them, this is what my plan would be. Is it going to be perfect, your plan? No, but it's the starting point. The next time somebody comes in, you go, oh yeah, I wrote that down. And pretty soon, after your third or fourth referral, you're like, well, this is what I do. Sam, can you take care of this for me? This is who we need to call. This is what we need to say. This is the documentation we need to send. And this is what I expect to hear back from them. And Sam goes, great. You've now just put a protocol in your practice that makes fear be empowering.
Yeah, I completely agree with that. And a couple things I'd like to add on that. As a newer OD, when you first start, you're not going to know who the best retinal specialist is in town unless you just happen to maybe done a rotation there and you've already gotten a little experience or whatever under your belt. Your days are probably not going to be slammed day one. You're going to have some days where maybe your schedule's half filled, you know. Try to utilize that time in your early career when you build those co-management relationships. You go and either see them or you talk to them or you call them on the phone and say, hey, I've got, you know, this case. Is this something that you need to see or can I handle this in my chair? When you have a support, not just within the optometric community, but beyond that, where you feel comfortable picking their brain and you feel comfortable with their opinions and what you can handle versus what you need to send on, that's going to help those protocols really solidify. And once you get a few of those retinal letters back and see that, guess what, they did the same thing that you would have done, you could have handled that, you feel a whole lot better the next time it's sitting in your chair going, I'm going to monitor you. I'm going to see you back in a couple of months. And if it gets worse or if it changes, then I've got my next step, but I can handle this.
That is a key pearl about chronic eye diseases like glaucoma and dry eye. They're typically not going to change acutely. Now, can someone have a flare-up or exacerbation of their dryness or their punctate keratitis or corneal erosion or whatever it may be? Absolutely. But for the most part, you have time to make decisions. These aren't acute referrals. These aren't, you know, send them to the emergency room. These are things that you can do in your office. You establish a baseline and you look for change over time. But going back to you know, referrals, one of the things that you should expect when you make referrals out of your office is you should expect mutual respect. So when you send a patient over, you don't want the doctor to keep the patient, denigrate you as a provider. Oh, that optometrist, he didn't know what he was doing. Or, oh, she's new, she really doesn't know what she's doing. I mean, this happens on a daily basis all over the country. The other thing you should expect is some type of written documentation as to what the diagnosis was, why you made that diagnosis, and how you're managing it. And so when you start these relationships, when you get into your practice, you need to go, as Patricia says, have lunch with the doctor. They would love to have your referrals. I mean, they would do anything in the world to get your referrals. So take advantage and leverage that. Go have lunch. Talk about what you expect. Say, hey, I'm a new practitioner. I'm not, you know, I don't have the most confidence in the world in managing complex conditions, but if you could really be deliberate about telling me what you did with this patient and why, it's going to help me become a better doctor. And I can just send you surgically relevant referrals instead of primary eye care type of referrals. The second thing I'd highly advise is that you go spend some time, you know, if you have a day off or take a half a day off. I know you've all just done externships and everything else, but now it's a little different. Now you're the doctor. You have your license, you're seeing patients, and I think if you spend a half day even with a glaucoma specialist or cornea specialist or a retinal specialist, neuro, whatever it may be, and just see 40 patients with them for a half day, it would literally change your life. I know it did for me. Even though I had a residency, I spent a half day with a cornea specialist in my hometown, and I learned 2 or 3 key things about corneal disease that I use every single day of my life. It wasn't a residency, it was 4 hours of my life. So we talk about workflow and everything else. Let's talk about equipment. I mean, with dry eye, you could get away with having a patient symptom survey. I like to use the speed score. It's you can download it, it's free. If you can print off the piece of paper, you can use it, and that's the only equipment you need. And it's 28 questions, or excuse me, it's a series of questions that lead to a point system that you add up. But we started about a year ago having every single patient that walks in our office, I don't care if it's for a contact lens check, a cataract post-op, a glaucoma evaluation, a comprehensive exam, contact lens, etc. We make them fill out this speed score. And what we've done is we've identified a huge portion of patients that didn't know how to tell us that they had dry eye. They don't know what to tell you. They are not eye doctors. So all they know is that they're having issues. They just can't articulate it to you.
And once again, you just have to ask the right questions. And if you don't know the right questions, a questionnaire is a very assertive way, if you will, in that you're saying, you tell me what's wrong, but here's the list of what could be wrong. And many people come back, as Ben said, and go, oh, I have this, this, and this. I guess I have dry eye. And you get to go in and be super doc and go, yes, you do. And now all of a sudden they're like, well, why didn't my other doctor treat this? I said, I don't know. Aren't you glad you're here? Right? And then after this discussion, usually kind of the follow-up discussion is they say, well, if you treat this, can I get back in my contact lenses? The answer is, I see no reason you can't. And now not only are you fix the dry patient and have the happiest dry patient in the world that's going to tell all their friends who can't wear their contacts either, you've now built your contact lens practice. And so as I said before, those things go hand in hand. And it does come down to technology of asking the right questions. And when you start with the low-hanging fruit. I mean, a soot lamp and some lissamine green strips are all you really need, an ocular surface and allergy. And that's a place to get started and build your confidence. And as you get more confident about what you're doing, maybe then you're going to buy an OCT, or you're going to buy a slit lamp camera, you're going to buy a retinal camera, and start advancing what you do built on your comfort level.
I think another thing that's important to remember is educating your staff on this same stuff so that they know the right questions to ask. They recognize those patients when they call. They recognize them when they walk in the door and say, my glasses just are not working for me. They're blurry half the day. Well, if it was refractive, they'd be blurry all the day, not just half. So there's something else going on there. They're probably dry. They're probably, if you're in Alabama, your car is yellow no matter what color your car is because it's pollen season. They probably got allergies, right? So there's so much more to it than just yourself. You don't run the practice yourself all day long, right? You don't schedule every appointment that walks in the door. You don't sell every pair of glasses that goes out the door. You've got to educate, have team meetings, make sure everybody is on board with this so that they're able to help build you up and make your job a little easier.
Well, one of the things I always tell them, Ben and I did the Student Practice Management Symposium series for 10 years. And one of the things we always discussed is that, especially for the folks who are just relatively new out of school, is you have a little time. There is no better way to ingratiate yourself to the staff than to take 5 minutes and teach them something. Because many times the staff wants to know, but no one's ever taught them or told them. Take 5 minutes and say, this is a question that I often ask about dry eyes. And these are the variable answers that somebody may give me back, and this is what it means. Well, that took me, 7 seconds to do that? Maybe it takes me 4 or 5 minutes. And interestingly enough is what happens, not only does the staff start scheduling, they start getting on the phone call and somebody says, my eyes are kind of a little irritated. Well, that's perfect. I have this new doctor, Dr. Brady, and she'd be great to help you treat what the symptoms you just discussed are. And all of a sudden, Kristen's going, man, my schedule's getting full. And the other doctors are going, why is Dr. Brady's schedule getting so full? And the staff goes, well, because Dr. Brady's the one treating the dry eyes. Well, how do you know about dry eyes? Well, Dr. Brady taught me. And so all of a sudden, if you want to build your own practice, one of the first places, Patricia said, is to start taking a few minutes of your time to train the staff about the right questions to ask on the phone and the right questions to ask to the patient when they walk in the door. And all of a sudden, you're going to find out that your free time is now less of that free time because you're more busy.
Just all the technology that we have to deal with sometimes distracts you from what you're doing. So for me, I couldn't make it through a day without a tech or a scribe.
And that's one of those things, especially for some of the newer docs, you might not be busy enough, you think, to warrant having a scribe or a tech that's in the room with you, but that time will come. And really, once you get to about 10 to 12 people a day, you need to think about that, because what is your time worth and how many more patients you could see if you had a staff member helping you out? And I know some practices that's kind of a nouveau thought, and well, I'm not really that busy, but the answer is you're only going to get more busy if you get more efficient. And the way you get more efficient is to have people help you.
And delegating is hard for some doctors. I'm in a practice with my dad has been practicing for 50 years this year. I have another doctor. She's been practicing for almost 35 years in our practice. And once you kind of get in your routine, it's not real easy to change what you're doing. And so to develop these habits early is really, really important. And you may walk into a practice and they're not going to have a scribe. They may only have one tech that does the auto refraction, checks the VAs, and sticks them in the room, puts the flag up, and says you're ready to go. But here's the point. They haven't been trained, or no one has thought to implement that. So in your downtime, you have a no-show or cancellation or whatever the case may be, go in and work with the technician. Show them what these terms mean. Show them how you enter things into your EHR. Show them examples of a cataract, of a glaucoma optic nerve, of a nerve fiber layer defect, whatever the case may be, because they are very compartmentalized. They say, I'm going into work today, I'm going to take 30 patients, I'm going to put them in auto refractor, I'm going to do a eye care tonometry, check their vision, and done. And you never know they never know what happened with that patient. So you've got to take the time and the initiative to show them, to help them become the person you want them to be. And you can do it.
And pull them into the exam lane. When you see something cool, pull them in and say, hey, come in and take a look at this. You see this little spot? That's the reason, that little spot in the cornea that's negatively staining, that's the reason they said when they wake up in the morning their eye hurts. They have what's called a recurrent erosion. These are the ones that call us at 4 a.m. Yes, you don't have to deal with that. I'm the one who has to come in the morning. But that's the one we see every couple days, and like, they saved my vision. And then the patient, the staff goes, oh, so when somebody says they have their eye hurts in the morning, that's what it could be. And he says, yes, and this is the other questions you ask. Pretty soon you're gonna come in and your history is very filled out, and the patients go, so I have this thing called a recurrent erosion, right? Yes, you do.
And I think you'll be surprised how quickly your staff gets energetic about these things when you actually involve them. When you bring them in the room, when you teach them, when you know, if you're getting a new piece of equipment or you're thinking about a new piece of equipment and you educate and you show them not only this is how you're going to use it, but this is how I'm going to make this work for the patient, how I'm going to treat them better. A lot of the staff will really latch on to that, and they'll kind of get a fire under them and want to help build that. And if they don't, and you start to go that direction and your whole team is really, really excited, and you see maybe one or two that aren't so excited, then maybe those people aren't necessarily the right fit for your staff and for where you're trying to take your practice, and it might be time to think about freeing up some futures and giving them other opportunities in their life.
That was nicely said.
You know, we have in our practice alone, I can think of 3 or 4 employees over the last decade that have gone on to become optometrists or ophthalmologists just by being a technician in our practice. Because someone took the time to say, hey, what do you want to do with this? Do you want to just sit here and process through 30 patients a day, or do you want to, do you want to make a career of this? And some of them actually will, and those are the most, I guess, satisfying moments of my career, is seeing someone come up with no experience at all, and now, they're a peer, they're a fellow doctor, which is really great. Well, in the last few minutes, I want to get a little more complex in our discussion about complex diseases. Let's take glaucoma, for example. So you're going to treat somebody or work somebody up for glaucoma. First of all, you're going to kiss a lot of frogs before you find your prince, meaning you're going to see a lot of glaucoma suspects that don't have glaucoma. But you know what? If they're glaucoma suspects, they still need to be followed. They probably need to be followed annually. And then you're going to find one finally that has glaucoma. You've diagnosed their glaucoma. And the question is, what do I do about it? And this is where most of the ODs that I know that don't do glaucoma kind of freeze up. They go, I don't know what to do. I'm going to send it to my ophthalmologist. You've heard of prostaglandin analogs, right? Lumigan, Travatan, latanoprost. Okay, my 15-year-old daughter could treat every one of you with the prostaglandin and nobody's going to get hurt, right? Nobody is going to get hurt. So it just takes that first confidence. And then the next step is, well, their pressure is going back up or their glaucoma is progressing. What do I do? And this is where most ODs I know really start to get a little uncertain of their care. Do I add a second drop? Do I send them off for laser? What medicine do I use? I don't know how much lower I need to get the pressure. How do you deal with those?
Well, I think the first thing to keep in mind is something that you touched on earlier, in that it's probably not going to change overnight. So if you try something and it doesn't work, it's okay. You can try something else. Or if you get that patient who truly just isn't responsive, there are some that it doesn't matter what treatment topically we put them on, it's just not going to work for them. There's your laser patient. There's your referral patient. If you need to pick up the phone and call that glaucoma specialist that you went and shadowed so you have a relationship with them and say, this is what I'm seeing on their OCT. This is why they're progressing. Maybe it's a blood pressure issue. Maybe you're having some, changes in the diurnal curve at night when they're asleep, when their pressure is going up, their blood pressure is going down, and that's something you didn't necessarily take into consideration. And then you need to partner with their PCP. There's a lot of different factors that you need to take into place, but I also want to back up just one step. In that first realm, say you're in a practice and you say, this person may have glaucoma, but I don't have an OCT, or I don't have a visual field because I'm in maybe a retail location where we just don't have that. Remember, you can refer out just testing, and you can still interpret that, and you can still bill for that as a professional component. So find a location in town that's willing to do testing. There's a lot of private offices that will do the testing only component and send that back to you and let you still manage your patient, but not have to put the expense of the equipment in just yet.
So what if someone, let's say for our new grads here, you're going into your first practice been around a while, you go in and they don't have an OCT, and you really want to treat glaucoma and retinal disease. You want to diagnose and manage that. How do you go to the owner doctor and say, hey, we need an $80,000 OCT?
Go ahead.
You may take that one?
Yeah.
So I get this question a lot. People say, how do I afford a new piece of technology? Well, I think there are two totally different methods. I don't care which one you use, just use one of them. So method number one is track it first. In other words, every time for the next 3 weeks, 6 weeks, whatever, I want you to carry a little sticky note around and say, this is a patient I could have done a retinal photo on if we had a retinal camera. This is somebody I could have or should have done an OCT on that I had to refer out if I had an OCT. Take it times 6 weeks, okay? Take that as an example. Then what you do is take that number, and you're gonna multiply times, it would be 8 times, right? That's about 48 weeks. Now multiply it times 3 years. Now multiply that times what would be the reimbursement level of an OCT or a retinal photo or whatever. If that number is greater than the cost of an OCT, then you can go to your owner and say, we can pay for this just on what I've seen over the last 6 weeks. Here's what it is annualized. It shows that you've done your homework and know that you can do it. Now, at that point, that's what helps you decide, should I buy this or should I continue to refer out? Now, that's the first step. Now, the owner may go, yeah, I ain't doing that. That's cost money, I don't believe in that, whatever. So then the proof's in the pudding. You guys have to step forward and say, you know what, then how about if I buy that, and instead of the practice getting the revenue for this, all that revenue comes to me. That's a no-threat offer to the owner, right? They're spending no dollars. They're also making no dollars. So now the impetus is on you to actually do what's clinically necessary, and if so, be able to get reimbursed for that, what you've spent on that piece of that device. Now all of a sudden you're gonna find out that, man, I use this a lot more than I thought because I find all kinds of clinically relevant things that would be necessary to use an OCT or photo for. So there are two ways. One, if you've given the proof and the owner doesn't want to buy it, then great, buy it yourself. And yes, you're like, but I don't know if I can get a loan for this. You go to the bank and say, this is what my portfolio is, this is what I think I can do, they'll give you a loan.
And the leases with the companies too, I mean, you could probably get a entry-level OCT today on a 5-year lease for $300 a month, $200 and something a month, and a $30-something reimbursement per scan. You can figure out pretty quickly that it's only going to take you about 10 or 11 patients a month, or less than a patient, pretty much 2 patients a week, something like that, 3 patients a week. That is nothing. I mean, I Monday morning when I show up in my office, I'm going to do 10 before I even start.
Monday by noon.
Exactly. Yeah, I mean, the biggest key in what both guys have said is do your research. Know what you're talking about before you take it to your practice owner, because if you go and you sit down and say, hey, I want that OCT because it's really shiny and pretty and I think it'd be cool, they're not going to listen to you.
That's a bad plan.
Yeah, I mean, you know, I went to a show and they showed me a really cool piece of equipment and I think we should use it. And as the practice owner, I say, okay, what can we use it for? Tell me what codes I can bill this for. And you say, I don't know, they just said we could do it. That's not going to go over well. Do your research, do your tracking. Whether you're going to buy it for yourself or the practice, do your tracking. Make sure that you know what you're getting into.
Just always make good clinical decisions and good business decisions. If you don't have the volume to buy something, don't buy it. Pretty simple.
It's like that new car. If you want that brand new Maserati and you can't afford it, well, don't buy it. Well, last thing before we kind of open up for questions, I want to cover a topic that will affect all of you, and that is surgical care. Not necessarily optometric surgical care, which some of us do, but when you have a patient that has a cataract, that has glaucoma, that has whatever surgical disease, is there any way that we as a practice, as a profession, as a doctor, can benefit from our patient having cataract surgery?
Absolutely. First of all, you build that relationship with your patient by recognizing those conditions that need the surgery, changing their life in that way, and bettering it, making sure that you've partnered well with your co-management physicians, so that like take where I'm practice in Huntsville, for example, we've got some great cataract surgeons, and they're each great at certain things. So knowing which one to send each patient to already is getting us a little bit of a step forward in the right direction. But then when they come back to you, when you're managing it, maybe their cataract's cleared up now, but you're able to see more of their diabetic ret. Or, they're still getting older and now they've got other issues that are forming. They've built that loyalty with you. From an optical standpoint, there's still a lot of options that you can do with cataract patients after surgery. There's things, whether it be, a presbyopic sunglass that they need because their distance is fantastic now, but they still want to read when they're on the beach. or their dry eye that became secondary to cataract surgery. Remembering these things that can manifest afterwards, and keeping that patient really well educated as to why it's important to come for care, because you get some of them in that same boat as the 20-year-old that says, I can see really good now, so why do I need to come back? Re-educating on making sure that they know that, and then they'll bring their patients and their family.
So if you don't know, when you do a cataract post-op under a Medicare, you're going to get about $100.
$138.02 is what the national average is in terms of co-management.
In my state, I get $98.32. So, in Kentucky, we're not worth as much. But what I'm trying to say is you're going to see that patient preoperatively. You're going to see him postoperatively. I see my patients day one, week one, so I see him the next day. Maybe you want the surgeon to see him the first day, and then you see him 1 week. But sometimes you're seeing these patients 3-4 times for each eye. And if they have a complication, then you're seeing them more and more, and it's all covered under that $98 reimbursement. So a lot of times you do a ton of work for not a lot of money. But if you looked at your patient and they had, a diopter and a half of corneal astigmatism, and they've never been able to wear contact lenses because of their astigmatism, and you say, hey, look, when we do this cataract surgery, I want you to think about the fact that we can use a toric intraocular lens. It's going to cost you more money because it's not fully covered, but think about being glasses free. Think about the options that you would have. Presbyopic correcting lenses. Maybe you want to encourage your patient to use a femtosecond laser instead of regular phacoemulsification because they have a faulty cornea. They've got Fuchs dystrophy. They have some other type of corneal dystrophy. By you talking to your patients about it and educating them, you're the real doctor in their mind. That guy's just putting that lens in their eye. But what usually happens, you don't say anything at all. They get to the surgeon, and then the surgeon overflows them with all these different options and how much it's going to cost them. And they really don't have the time to spend with that patient. And the patient gets home and they call you and they say, Doc, I'm confused. I don't know what I'm supposed to do. It's going to cost me $5,000 to have cataract surgery.
Well, and I think that Ben brings up a great point. When we talk about how we treat patients, one is we always want to do it's in their clinically best interest, which is to discuss their options. Glasses, contacts, refractive surgery, which these days cataract surgery is really a refractive surgery option with a medical diagnosis. And as Ben said, you're talking about toric IOLs, you're talking about multifocal IOLs, you're talking now about toric multifocal IOLs. And, don't worry about the money part. That's not your discussion. Get your head out of their pocketbook. That is not your choice decision to make. But it is our job to discuss their options with them so that they have time to think about what they want to do. And when they go to the surgeon, the surgeon lays out all these options, say, oh yeah, Dr. Morris already discussed all those with me. This is what I want to do. Surgeon goes, fabulous. We don't have to spend 20 minutes discussing it with you. And if you're not comfortable with what a toric IOL is and what the post-operative issues are or multifocals toric, spend that quarter day or half a day, as Ben said, going into that surgeon's office and spending some time talking to them and listening to what those premium IOL options are. That's how we treat the patient. And when the patient says, yeah, like they said, come back and said, Dr. Morris discussed that with me, they're going to be much more loyal towards coming back to me for the rest of my life than if, oh, well, that's a surgeon's job to talk about that. The surgeon doesn't know the patient. You do.
Yeah, absolutely. I think being in a co-management practice, some of the bigger obstacles that we face, that we see, are patients that come to us who haven't been pre-educated, who haven't heard anything else about these other options, and they come and they sit in the chair. They're already scared. They're scared because they have a cataract and they're going to have surgery, and they don't understand like we do that that's a common procedure. It's their eyes, and for them it's a big deal. And so they're already a little bit fearful. They're already a little bit shut down, stressed out. So they're hearing maybe half of what the surgeon's saying anyway. And then they throw all these lenses at them. And now they're even more overwhelmed. And they're looking at numbers and they're looking at figures. And they're trying to figure out, why am I going to spend this for that one when my insurance covers this one, and what's this and that? If we take that role on first and we talk it through, first of all, keep yourself educated, read, make sure you know what's out there, make sure you know why and what patients those fit, so that you're presenting that in a way that they can understand, and in a way that makes you look knowledgeable about the situation, so that they feel that they can trust you. Then when they get to that seat, they are much less likely to make the wrong decision. They're much less likely to, after cataract surgery, say, I really wish I'd gotten that toric, but I didn't understand. Or I really wish I hadn't done monovision because now I really can't see depth at all. But, that's what I thought I wanted at the time. You're going to head off a lot of these headaches because the patient is going to then lump you in with the surgeon of why didn't you educate me if they come out poorly in the end. So the more education you can do on the front end, the better. Talk with your patients.
And if you think about that $98, let's say they got a toric intraocular lens, that $98 now goes to about $400 per eye, right? So $800 instead of $180 something. And if they get a multifocal IOL, that could turn into well over $1,000 in co-management for your practice when you were getting $98 before. I mean, that's a huge difference. The flip side, and Patricia kind of touched on this, is if you don't say anything about the options, they go to the surgeon, they get the latest and greatest multifocal IOL. And the surgeon doesn't talk to him about the fact that, well, your distance is going to be great and your intermediate's going to be great, but your near vision is going to be terrible. Or your near vision and your intermediate's going to be great, but you're going to see halos at night for the first 3 months, or whatever the case may be. And then they have the surgery, they pay the money, and they come back to see you, and they are furious. They can't see. They're seeing worse than they did before. And guess who gets to deal with that? You all do. I have had patients sit in my exam room for hours crying because they were nearsighted before they could take their glasses off to read. Now all of a sudden they can't. And it was my fault. And you know what? It was my fault because I should have educated them better about what their options are and what their outcomes could potentially be. And so anyhow, do we have any questions from the audience about what we talked about this afternoon?
This might not happen all that often, but you had mentioned in the age of deductibles and out-of-pocket expenses. How do you handle a situation where you might have a patient who, needs glaucoma testing, they're suspect, and you explain it to them, you educate them, and you say we need to have you back for some additional testing, and they say, oh well, is this going to cost me? And you have that discussion with them, and then they say, oh, you know what? No, I don't want that testing. And you educate them why it's important. They still kind of refuse. What do you do in that situation? Do you just tell the patient, well, I don't know if I can, care for you then, or what?
That's a fabulous question, and I will say this true of every test that you're ever going to do, diagnostic test, including refraction. If you can't give them a good clinical reason to do it, you shouldn't be doing it. Number one. Number two, if they still resist, it is ultimately their decision. Now, you need to always CYA and document in the chart, explain to patient risk, benefit, alternatives to this particular diagnostic test. Patient chooses to not perform this test for whatever reason. Okay? Fantastic. You've now done, from a medical ethics standpoint, exactly what you need to do. If you feel strongly, you try to keep convincing them. But ultimately, it is not your job to decide what they want to get. It is your job to be their consultant and educate them about what they need and why they need it and what the rationale for doing that test is. But you can't make someone do a test.
It's not your fault that the patient has a $10,000 deductible.
Right.
You didn't choose their insurance plan.
Absolutely.
Not your problem.
No, you didn't. And you also, while it is our responsibility to educate and take care of our patients, you can't make their mind up for them, and you can't make them pay that bill if you do the test and then they do get billed for it. So educating them up front, you can consider signing ABNs if that's something that,
Not consider. Always.
Yes.
As a Medicare patient,
Completely agree.
always get an ABN. The only thing you don't have to get an ABN is a refraction.
Yes.
Everything else, you have to get an ABN, and anybody who's got Medicare. But all the rest of them, you should always discuss what, why, where, and how of the testing, but also how much it's going to cost before the test is done, not after the test is done. That will prevent all kinds of blow-ups, both in the office and 2 months later when the EOBs come back. Absolutely.
And from a medical legal standpoint, though, like you were saying, some patients are going to choose just not to do it. As long as you document, like we were talking about, if you put it in your chart, I can't tell you how many charts that say discussed XYZ with patient, patient denies treatment, or patient defers treatment, or patient chooses X. As long as that's in there, you're going to be covered. Just make sure you document.
Thank you. I guess I got another question. Early on, when you're starting your medical practice, maybe you're not, that busy with medical yet. Is there any advantage at all to have like dedicated days for visual field testing? I mean, that might be a practice flow thing, but
Yeah, so we hear of practices that do this, that have a special day. I think unless you have enough volume of disease patients to do that, you're going to be sitting around most of the day. For a couple of reasons, I'm just going to give you my perspective. I like working it into my daily flow. Number one, it gives me variety in my day, right? So I'm doing different types of care. Might be a refractive vision care plan patient, and then I walk in and see a corneal ulcer, then I see a pediatric patient, then I see a glaucoma patient. It also keeps, so if you've ever performed a visual field, anybody in here performed one, given one? It's not fun, is it? It's not fun to give them. It's not fun to take them. Could you imagine sitting in a room all day long doing nothing but visual fields as an employee? Yeah, they're going to quit in about a week.
Your visual fields are going to get a lot worse too, because your staff's going to check out about halfway through, and they're like, whatever.
So for that reason, I typically don't do a specialized day. Highly encourage you to try and integrate it as much as possible with the right flow and systems in place to be able to facilitate it and the right staffing requirements. But if you, like, for example, on Wednesdays, Dr. Paul Karpecki and I have a dry eye clinic. It's a specialty clinic. We get referrals from optometrists, ophthalmologists, internal referrals, and they're all advanced dry eye, and that's all we do all day. That's really an exception. It's taken me 20 years to get to that point that I could actually do that. So that's how I answer it.
I think on that point, if you are going to try to build a day that's a specialized day, really look at your practice, look at what days are your busiest days, look at what day is your non-busiest day, and really say, okay, Friday afternoons in our region just aren't that busy. Let's start targeting that for this specialty practice and filling that with these patients that need to come back anyway. And then that way you can build into a day like you have where it truly is a specialized day. Also, on bringing people back just for testing, I think if you're the patient in the chair, think about what you would want. If you have the time to do it there that day and you've got the staffing, would you really want to have to come back to do something you could have done that day? Probably not. So I would try to err on what you would want done for yourself.
Patient's best interest.
Absolutely.
So Thursday's glaucoma day, but your patient cannot get off work on Thursdays under any circumstance. Oh, well, sorry.
I got a question. Getting started in practice, especially if you're bringing medical in, I think coding and billing is extremely daunting for a lot of new graduates. Maybe we could squeeze by on the coding the exam ourselves and learn the hard way, but submitting it and getting paid and checking the remittances and whatnot. Do you guys suggest, would the best thing to be to learn it, hire a staff member, or outsource it, or something else?
I'll definitely take that one. I think that first of all, it is always the doctor's responsibility to code the exam, period. Never, ever, 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 ever should a staff member be coding your exam. They weren't in the room, they don't know. If you have a scribe, maybe, and they're well trained on how to code, maybe. But the reality is you all need to know how to code the exam.
It's your responsibility.
It is your
And you're still signing the
medically,
EOB.
legally, it is your responsibility. If they do it wrong, it still comes down on you. So it's always your responsibility. Coding is not difficult. It's really not difficult. There are basically 3 codes: 9921, 9920. But if you think about it this way, it's very simple. In fact, eye care coding or vision care coding with 92s is way more difficult than 99s. Way more difficult. The rules are very clear in our 99 codes. Very clear. And so now, so the coding part of this, pretty simple. The billing part, meaning the submission, the reimbursement, all that kind of stuff, the answer is I do think you all should do it in the beginning so you have an understanding of what that's like. But eventually you're going to get to a point where as you grow your practice, it makes more sense from a value perspective for you to not be spending your time doing that and to hire someone out, either a billing agency to do it for you, because they're just taking the code you produced and doing the processing through some processing, or actually having someone in-house. And that's going to be different for every practice at every different stage. I mean, Ben and I, our practices are very well established. We have specific people that just do the taking it from where we leave the codes to the submission and everything else. But it is a process. But I'll tell you, I still to this day can do that myself if I have to. It just doesn't make a lot of sense financially to do that. I'm paid, just like a surgeon's paid to be in surgery, we're paid to be in a lane seeing patients.
Yeah, absolutely. And keep in mind when you first start, if you come into a practice that's well established and they've already got somebody doing that, that doesn't mean that you can't learn it still. You learn your coding. There's a lot of resources out there that get into what you can code with this or can't code with that, all the criteria that the 99 codes require. making sure that you understand all of that. But on the billing side of it, if you've got somebody in your office that you're coming into that's, you know, doing that for you, ask for your EOBs to start with. Look at those, try to understand them, make sure you know why we're having to resubmit that claim or what we could have coded a little differently to get a better outcome.
Why it was denied.
Yes.
And sometimes you got to go to the insurance companies and say, hey, I need you to walk me through. Why was this denied? Oh, well, that's a mutually exclusive code. Well, now you know. But before, you might just say, oh, I didn't get paid for that one. Next, didn't get paid for that one. I can't tell you how many practices we go into where it's just been written off or slid under the table because they don't really know what to do with it next.
My friend John Rampakis and I do something called OD Boot Camp. And I'll tell you that that is the biggest single question. People don't understand why they didn't get reimbursement. 99% of the time, it's because we didn't code something correctly. Well, we can keep coding it incorrectly and keep getting denied, or we can actually say, you know what, it's my responsibility to learn and fix it. 1% of the time, it's because the insurance company made a mistake.
And Ben touched on write-offs really quickly. I think, especially new grads, don't jump straight to a write-off just because you got an EOB back that got
Never.
denied. Resubmit that, research it, figure it out. And there's going to be certain cases where there are parts that you have to write off. That's just part of our environment. But don't do that unless you completely understand why you are doing it.
Writing off is definitely an exception,
Yes.
not the rule.
Not the rule.
If you're writing it off, it's usually because they didn't have coverage or you weren't credentialed.
And don't feel bad about putting that toward the patient if it's truly a deductible issue, if it comes back and that, because you should have had that conversation up front. The patient should know that they may owe this in the end. But also, like Ben said, it's not our fault that they chose a $5,000, $10,000, $15,000 deductible. Unfortunately, most patients walking around these days, even though they have an insurance card, are virtually uninsured. All of this is now on them to do. They should be expecting a bill. And just because you're going to have to send them one, it's not your fault. It's not a bad thing. It's a business. You've got to recoup that money, and you did the service. Make sure you're billing for it.
Thank you. Anyone else want the mic for a question?
Well, love to thank my distinguished panel here. And good luck to all of you. Know that we're always here for a resource. Just reach out to us if you need us. Thank you.
Thank you.
Thanks, guys.
Thank you.